Hello, everybody. I'm Mary Fiersten. I am the OG Woo therapist. As you know, the topics I talk about are things I learned both as a client in psychotherapy and as a therapist. This is not intended to take the place of counseling or therapy, but to highlight some of the issues that could or need to be addressed with a licensed counselor or therapist. And for some, it will be educational information to increase understanding of therapeutic issues. None of the information that I am going to talk about should be used to self-diagnose or diagnose anybody else with a mental health disorder. Only a licensed practitioner can do that through the process of differential diagnosis. Today, I'm going to talk about dissociation and give a brief overview of dissociative disorders. The core conceptual differences between PTSD, CPTSD, and dissociative disorders are that PTSD and CPTSD are about a primary disturbance in threat processing and fear regulation, and trauma is remembered but experienced as intrusive and overwhelming. Dissociative disorders are where there is a primary disturbance in integration of identity, memory, and consciousness, and trauma is compartmentalized, fragmented, or inaccessible. Dissociative disorders are more common than most people think and are often misdiagnosed. DID is rare, but it is real. Media portrayals are often inaccurate, and dissociation is not malingering or attention-seeking, as we often see portrayed on social media. And people with dissociative disorders are suffering in their attempts to feel and appear normal, quote unquote, in their lives. Dissociative disorders are mental health conditions involving a disruption of disconnection in normal integration of these 7 paradigms of personality and identity. Consciousness, or the awareness of the mind of itself and the world. Memory, or the encoding of information that can be retrieved when needed. Identity, or the fact of being who a person is. Emotion, a strong inner feeling about internal states and external stimuli. Perception, or the awareness through physical sensation. Body awareness, or the internal sense of body parts and where they occupy space. Sense of self, or how one sees himself. Dissociation exists on a continuum from common mild experiences like daydreaming or zoning out to more severe chronic disorders like dissociative identity disorder. Dissociation is an amazing protective survival response of the brain. It is not a sign of weakness. It mostly develops in response to overwhelming or inescapable stress, especially when escape or resistance is impossible. And it is strongly associated with chronic trauma, particularly in early childhood. Here are the core dissociative disorders according to the DSM-4, the Diagnostic and Statistical Manual 5, TR, starting with the most severe and disruptive. First, we have dissociative identity disorder, which is the most severe of dissociation disorders, or DID. It's at the far end of the continuum and is where there is a presence of 2 or more distinct identity states and there are gaps in memory inconsistent with ordinary forgetting. There is significant distress or impairment in living a quote-unquote normal life, and it is not due to the use of substances or cultural practices. DID is often linked to severe repeated childhood trauma, where pieces of the developing personality are chipped off in response to the trauma during a dissociative episode to protect the psyche. Identities may differ in emotions, behavior, perceptions, or sense of self, and may even be so different that one may need glasses where others do not. Memory barriers exist where one part does not have access to the memories of the others, and they are extremely common between the identities. There is also an experience of loss of time when there is a switch in personalities. This will be discussed further in a future podcast. Next, we have dissociative amnesia, and that is where the individual has the inability to recall important autobiographical information, like not remembering fifth grade or other important events that took place in life. Dissociative amnesia is usually trauma-related. However, memory loss is reversible with the help of a trained therapist. We sometimes call this type of memory loss ego state dissociation or structural dissociation. These will be discussed further in a future podcast as well. There is a subtype of dissociative amnesia called dissociative fugue, and this includes the incorporation of sudden travel with loss of identity awareness. And this occurs very, very rarely. Next, we have depersonalization and derealization disorder, or DPDR. And this is where there is a feeling of being detached from oneself, like feeling unreal. Derealization is feeling detached from the world, where the world feels unreal. Both can include the experience of feeling outside of the body. However, reality testing remains intact. A very mild example of derealization from my own life is that occasionally I will stop at a four-way stoplight and look around at all of the cars, and I will say to myself, wow, I had no idea any of you people existed until this very moment. That is a very, very mild example of where the world just for 1 minute felt unreal. This is not problematic for me because I'm able to bring myself back into the here and now instantly. This is not the case for folks diagnosed with these disorders. Their experience persists and impairs their functioning. Depersonalization and derealization often occur with anxiety or panic disorders. They can be chronic or episodic, and the individual experience is internal, not psychotic or externally created. There are common symptoms across the continuum of dissociative disorders, and these include memory gaps, feeling detached from thoughts, feeling detached from emotions and the body, an altered sense of identity, time distortion, emotional numbing, feeling unreal or disconnected from surroundings, and trance-like states. The relationship of dissociative disorders to trauma is strongly associated with chronic interpersonal trauma like childhood abuse or neglect, attachment trauma, which I will discuss in a future podcast, and long-term domestic violence. Dissociation frequently coexists with PTSD or CPTSD. This is the case with 80% of my clients. There are some clear distinctions between dissociation and psychosis, which is often a misdiagnosis, especially for DID. Today, many mental health professionals do not, quote unquote, believe that the diagnosis of DID is real, and they will treat the individuals for psychosis-related disorders like schizophrenia. The easiest way to clear a misdiagnosis is when asking if there are voices that are heard, and that is to clarify if the voices are inside their mind or coming from outside of their person. DID voices are internal and more conversational, and psychosis voices are external and usually always persecutory. These are the primary differences between dissociation and psychosis as well. With dissociation, the individual is capable of insight and self-reflection. The experience is with internal detachment, hence the internal voices, and is trauma-linked. Insight is impaired with psychosis, and there is an inability to self-reflect during a psychotic episode. Psychosis distorts external reality, and visual and auditory hallucinations are experienced frequently. Psychosis is usually biologically driven because of something different with the brain. Diagnosis for dissociative disorders requires careful clinical assessment. They are often underdiagnosed or misdiagnosed, as I mentioned before. The most common assessment tools are the Dissociative Experience Scale, or the DES, and the Multidimensional Inventory of Dissociation, or the MID, which we lovingly call the MID. I use both in my practice, and if the DES indicates a high degree of dissociation and a lot of time distortion, then I will use the MID to assess for DID. Before I use the MID, I do a differential diagnosis based on the information and symptoms of my clients. This is the informational decision tree to assess for PTSD, CPTSD, and dissociation. So the first step, I need to confirm trauma exposure by asking, is there a history of traumatic exposure? So if the answer is no, then I consider a non-trauma related diagnosis. If the answer is yes, then I proceed to the next step. Step 2, I need to assess core PTSD symptoms by asking, are the following present? Has it lasted for more than a month? Is your function impaired? And are there intrusions, avoidance, persistent threat, or arousal? If the answer is no, then I want to consider that maybe this is just a dissociative disorder or some other kind of disorder. If the answer is yes, then I'm going to proceed to the next step. In step 3, I need to assess pervasiveness versus fragmentation. Are the symptoms continuous or state dependent? Do they happen all the time, or do they only happen when I'm feeling like this? If they are continuous and pervasive, then I need to proceed to step 4A. If they are episodic or state dependent or discontinuous, indicating fragmentation, then I would proceed to step 4B. So in step 4A, where the symptoms are continuous and pervasive, then I will evaluate disturbances in self-organization as an indicator for CPTSD. I will assess affect dysregulation, chronic shame, negative self-concept, and relational difficulties. Then I will ascertain that there are PTSD symptoms only, and if there are, then the diagnosis would be PTSD. If there are PTSD symptoms along with the disturbances in self-organization, then the diagnosis would be CPTSD. In step 4B, where the symptoms are episodic or state dependent, then I will evaluate dissociative features. I will assess for memory gaps beyond ordinary forgetting, depersonalization or derealization, time loss, identity confusion or identity states, state-dependent skills, emotions, or beliefs. And that refers to, are there certain things I can do when I feel certain ways or I'm in a certain frame of mind, which would indicate some kind of switching. If it is present, then I will proceed to step 5. If it's not present, then the diagnosis would be PTSD with dissociative features. Step 5, I need to identify the dissociative pattern. Is there memory loss without identity fragmentation, which indicates dissociative amnesia? Is there persistent depersonalization or derealization with insight, indicates DPDR disorder? Is there identity fragmentation and amnesia, which indicates dissociative identity disorder or DID? The next step, step 6, I need to rule out alternatives to these diagnoses. So I will figure out, is there reality testing intact, which rules out psychosis? Are the symptoms trauma linked, which rules out primary personality pathology like borderline personality disorder? Or are they mood or anxiety symptom related? Step 7, here I identify the treatment implications. I do an assessment for informed trauma care. For PTSD, the care would be trauma-focused therapy, and it's often appropriate early in treatment. For CPTSD, it would include phased, attachment-informed treatment is necessary. For dissociative disorders, stabilization has to happen first. Then we can proceed to trauma processing once they are stable in function. Now let's talk about treatment. Dissociative disorders are treatable, but treatment is typically longer term and phase-based. These are the common treatment principles when working with dissociative disorders. Number one, stabilization and safety is where we focus on grounding, emotional regulation, and reducing the dissociation episodes. Two, trauma processing, which is where we focus on gradual, titrated trauma work, and we must at all times avoid flooding, because flooding can lead to a reactivation of trauma. Third is integration, and this is where we focus on increased coherence of identity and memory and improved daily function. This is an important thing to note. Many times folks come into therapy wanting to feel better fast, and sometimes that is possible with PTSD. But with CPTSD and dissociative disorders, premature trauma processing can worsen their symptoms. Here are some vignettes to demonstrate the differential diagnosis process for PTSD, CPTSD, and dissociative disorders. So if I'm working with, in case one, if I'm working with PTSD, a single incident trauma, my questions would be something like, can you walk me through what you remember about the accident? What happens in your body when you're reminded of it? Are there specific triggers that bring the symptoms on? Then I would ask questions to determine the time course and pervasiveness. So I would ask something like, do these symptoms come and go, or are they present for most of the time? And I would also ask, how do you feel about yourself and your relationships outside of those moments? The differential focus would be looked at next, and I would ask questions like, have you noticed gaps in memory or times you can't account for? Do you ever feel disconnected from yourself or the world? And you can see that these questions directly ask about symptoms related to CPTSD, dissociation, and depersonalization and derealization. The goal is to confirm trigger-based symptoms, intact identity, and absence of dissociative amnesia. So in the second case example, where we are looking at CPTSD, which involves chronic interpersonal trauma like childhood abuse or domestic violence, some questions I might ask to determine the trauma history. How long did these experiences go on? And I might ask, at what age did they begin? And I would ask, was there anyone you could turn to for safety at the time? Then I would be asking questions to look for affect regulation. So I would ask questions like, what happens emotionally when you feel overwhelmed? And I might also ask, how long does it take to calm down once you're upset? Then I need to ask questions to evaluate self-concept. So I might ask something like, how would you describe yourself as a person? And I might also ask, what beliefs do you hold about yourself when things go wrong? Questions to assess relational patterns would be asked next. So I would ask something like, how do relationships tend to feel for you over time? And I might also ask, what happens when someone gets emotionally close? The differential focus here is, do these difficulties feel present even when you're not reminded of the trauma? The goal is to identify disturbances in self-organization that are persistent and global and not episodic, which determines the diagnosis of CPTSD. So case 3, PTSD with dissociative features. Some questions I would ask would be to determine the PTSD core symptoms. What memories or images intrude when symptoms are strongest? And I would ask, what do you avoid because it brings those memories up? Questions I would ask for dissociative screening would be like, do you ever feel numb, far away, or detached during periods of stress? And I would ask, does that feeling pass once the stress decreases? Then I would ask questions to determine continuity of the experience. So I would ask something like, do you ever lose time or find things you don't remember doing? Like purchasing something and have no recall of making the purchase, or rearranging your furniture and don't remember doing that. Does the feeling pass once the stress decreases? The other thing that I would ask is, do others notice sudden changes in you? The goal is to differentiate situational dissociation from structural dissociation. Case 4, where we're looking at dissociative amnesia, I would ask questions for memory assessment, like what are there specific periods of your life that feel blank or inaccessible? And I would ask, what happens when you try to remember that time? Then I would also assess for context and triggers. So I'd ask questions like, did the memory loss begin after something stressful or traumatic happened? And I would also ask, do memories return spontaneously or in certain settings? Then I would ask some rule-out questions. Have you ever had head injuries, seizures, substance use during that time? And I would also ask, how do you feel emotionally when you notice the gaps? Then I would ask questions to assess identity and functioning. So I would ask something like, do you feel like the same person now as before? And I would also ask, do others notice changes in how you act? The differential goal is to confirm trauma-linked amnesia with identity fragmentation. So next, to assess for depersonalization and derealization disorder, I would ask questions to assess phenomenology. So they would be something like, when you say you feel unreal, what does that experience feel like? And then I would ask, does it affect your sense of who you are or more how you feel? Then I would ask questions to assess insight and reality testing. And so I would ask something like, do you believe this experience is happening inside you or imposed from outside? And then I would ask, do you ever worry you're losing touch with reality? Questions to assess if there's an anxiety link would be questions like, what tends to make these sensations worse or better? And I would also ask, did they begin during a period of intense anxiety or panic? Then I would make a trauma assessment. I would ask, have you experienced overwhelming or ongoing stress in your life? And do memories intrude, or is it more a constant state? The differential goal is to distinguish persistent depersonalization and derealization from trauma intrusions or psychosis. Then in case 6, assessing for dissociative identity disorder, I would ask questions to assess for amnesia and time loss. So I would ask a question like, do you ever lose time or find evidence of things you don't remember doing? And then I would ask, how often does this happen? Then I would assess for identity experience. So I would ask questions like, do different parts of you feel very, very different from one another? And then I would ask, do these parts have their own feelings, memories, or roles? Then I would assess for external feedback. I would ask something like, have others commented on changes in your voice, posture, or behavior? And then, how do you feel when that happens? Questions to assess for trauma would be, what was your childhood environment like over time? And I would also ask, were there periods where you felt you had to escape mentally? Then I would have to assess safety and stabilization. So I'd ask questions like, how do these experiences affect your day-to-day functioning? And what helps you feel grounded or present? The differential goal here is to identify identity discontinuation and amnesia and state-dependent functioning. Case 7, just as a contrast case, this is how I would assess for psychosis. So I would ask questions about reality testing, and they would sound something like, how certain are you that others are inserting thoughts into your mind? Or questions like, is there any possible or possibility of another explanation or one that could exist? Questions to assess the trauma link would be, did these beliefs begin after a traumatic experience, or do they change when the stress changes? Then I would ask questions to assess their insight and flexibility. So I would ask something like, what do others say about these experiences? And I would ask something like, how do you respond when they disagree? Then I would ask questions to assess functional impact. How are these experiences affecting work, relationships, or daily life? The differential goal is to differentiate fixed delusions and impaired insight from dissociation. Some of the key takeaways I hope you got out of today's podcast are that dissociation is a neurobiological adaptation to ongoing trauma. It protects the person when escape is impossible. It reflects fragmentation, not fabrication. And trauma-informed assessment and pacing of treatment are essential. Well, that's it for today. I hope you found this information helpful in increasing your understanding of dissociation and dissociative disorders. I will discuss the main types of dissociative disorders that I work with in my next podcast. Thank you for listening, and I'll talk to you next week.